my main focus is resistant infection in cystic fibrosis patient and treating infection in immunocompromised patient like cancer patient and post-transplant. So we'll get ahead and get started. I have few disclosures. I was one of the fellows who participated in Patrick Nash Fellows training program. And you can see me there in the picture. I also had like some travel grants, none of which are relevant to our talk today. So the objective of my talk today, we're gonna describe infectious challenges in aging people with cystic fibrosis. We're gonna talk about cystic fibrosis specific pathogens and their clinical implications, and we'll discuss the management of resistant infections. We're also going to talk about how to evaluate the optimal duration of antibiotic therapy for infection and exacerbations, and review some future antimicrobials. So as you know, cystic fibrosis result due to defects in the CFTR protein, and that will lead to thick mucus secretions impeding effective airway clearance. So due to that impaired clearance, we cannot get rid of the microorganisms that we inhale from the environment, and that will lead to chronic infection and over-exaggerated inflammatory response. And that inflammation causes pulmonary damage in the form of bronchiectasis, which further impairs airway clearance and leads to that vicious cycle of infection, inflammation, and lung damage. So now we're living in a different era. People are living longer, which is great. And that's largely due to the modulator therapy and better prevention and treatment strategies of infection. However, it brings also new challenges to all fields, but especially in infectious diseases. Now we see more recurrent and resistant infections and adverse side effects and intolerances to certain antibiotics. Also, the demand for non-pulmonary organ transplant has increased. I see people with cystic fibrosis after liver transplant or kidney transplants. And that brings also the burden of transplant-related infections or immunocompromised-related infections. And also people, unfortunately, are having cancers and the associated chemo, immunotherapy lead to atypical infections or more resistant infections. As you know, we have main pathogens associated with cystic fibrosis. Staph aureus remain the most common and always associated with poor outcomes, especially MRSA. Pseudomonas has decreased in prevalence over the years, which likely due to eradication therapy. But we see it more often in aging population. And now we have enough data to support that Pseudomonas infection is associated with loss of pulmonary function and decreased survival. Luckily, other pathogens like Burkholderia species complex, Chromobacter, and Stenotrophomonas are not as prevalent, but they are associated with even worse prognosis compared to Pseudomonas. As you notice here in the graph, after the age of 35, the prevalence of Pseudomonas increases and surpasses that of Staph aureus. And this is mainly because Pseudomonas tends to persist once acquired and adapts through biofilm formation and ultimately dominates the damaged CF lung environment. I'll talk quickly about CF exacerbations. The CF field has not reached a consensus definition of pulmonary exacerbation for the purpose of patient care or clinical research, but we can say it's an acute episode of worsening clinical and pulmonary status, often triggered by infection and require antibiotics. Luckily, the percentage of people with cystic fibrosis treated with IV antibiotics has decreased since 2019. And most of the time, we use systemic antibiotics or IV antibiotics to treat acute pulmonary exacerbation. Although that is universal practice, it is based primarily on clinical experience. So, how do we select the appropriate antibiotics for each infection? There are certain things to consider, like the pathogen isolation in cultures, prior cultures, antibiotic susceptibility testing, and the severity of exacerbation. Also, another thing that we have to keep in mind, antibiotic allergies and intolerances, which kind of limit our options in a lot of cases. And that brings me to talk about resistant infection. So why are we dealing with resistant infection, and why do resistant infection develop in the first place? We have two main things. First, the bacteria themselves, the genetics and adaptation with time. And the other reason is inappropriate antibiotic use. So the first reason, as you can see here in this image, there are multiple things for bacteria or multiple mechanisms that the bacteria develop resistance. I'll start from the top left. The bacteria can develop new cell processes that avoid using the drug's target, or it can change or destroy the antibiotics with enzymes, and that's the most common type, and or can change the entry site or limit the entry of the antibiotic to the bacteria and rendering the antibiotic ineffective. Or sometimes they develop pumps to kick the antibiotic out of the cell, out of the bacterial cell, so it won't work. Or change the drug's target so the drug can no longer act or function. Or dilute the drug by producing more targets than the drugs can bind to. What about inappropriate antibiotic use or even antibiotic use in general? Imagine that you develop a urinary tract infection. You go to urgent care or see your primary care doctor, and they prescribe antibiotics. These antibiotics do their job. They kill the bacteria causing your infection, but there's a catch. They also wipe out many of the good bacteria that you have in the gut that normally help you or help protect you. Now, the bacteria that survive are often the ones that are resistant to the antibiotic you took. With the good bacteria gone, these resistant bacteria have space to grow and multiply. And even worse, they can share their drug-resistant genes with other bacteria, creating new strains that are even harder to treat. So now we know why resistant infection happen and develop. Now let's explore these specific pathogens through clinical cases that bring their challenges to life. So I'll start with a case number one. So we have a 28-year-old woman with cystic fibrosis admitted to the hospital with worsening productive cough, shortness of breath, and fever. She reports increased sputum volume was changed from her baseline yellow-green to thick rust-colored sputum. She also notes mild chest discomfort and fatigue and reports no recent sick contacts. We look at the CAT scan of her chest and we see right upper lobe consolidations and multiple bronchiectatic segments. She's allergic to Bactrim or trimethoprim sulfa, and her induced sputum and blood cultures are positive for gram-positive cocci in clusters. We wait for the susceptibilities, and they come back with methicillin-resistant Staph aureus. It's fairly susceptible to certain antibiotics, as we expect, and resistant to basic penicillins. As you can see on the susceptibility testing, that's normally how we get the report for each bacteria. And the S stand for susceptible, R for resistant, and sometimes they report I for intermediate. The numbers that you see next to each antibiotic represent something that we call MIC, or minimum inhibitory concentration, which is the minimum concentration of the antibiotic needed to inhibit the growth of the bacteria. The less is better, and it varies based on the antibiotic. So to talk about Staph aureus, it's a gram-positive cocci. It's a common colonizer of skin and the nose, but can cause severe infection with poor outcomes. We have certain types based on the susceptibility. We have methicillin susceptible Staph aureus, or people called MSSA, or we have MRSA, methicillin resistant Staph aureus. And if we look back at the susceptibility testing, you see that next to vancomycin, the MIC, or the minimum inhibitory concentration, was 1. If that starts to increase up to 4, 8, 16 or more, then we have vancomycin intermediate Staph aureus or vancomycin resistant Staph aureus, or vice versa. Luckily, they are extremely rare, but that's the future, which is kind of scary. And these kind of things keep me awake at night. The mechanism of resistance of visa and versa are basically what we said in earlier, MIC creep, like the MIC is going up, and that happens with prolonged exposure to vancomycin. Or the bacteria changes the its cell wall, and prevents vancomycin from working, or due to gene transfer between the bacteria or among the bacteria. As you can see here in this graph, luckily Staph aureus infection has decreased by years, and the prevalence is decreasing. To treat MSSA, especially for lung or for pneumonia or pulmonary exacerbation or even bloodstream infection, we use 2 IV antibiotics, cefazolin and nafcillin, and we have oral options for mild exacerbation like trimethoprim sulfa, doxycycline, or augmentin. For MRSA, we use mainly vancomycin in the hospital. Linezolid is another option, but has some side effects, especially low platelet counts, which happens 2 weeks into therapy for some reason. And we have an option called ciftereline. We don't use it initially, but we save it for more resistant infections. Linezolid has an IV form and an oral option, so we can use it as a step-down therapy or in the outpatient setting as well. Visa and versa, hopefully we don't deal with them, and they are extremely rare in the United States, but our options are linezolid, and as we said earlier, limited by toxicity. We also have dalbavancin and oritavancin, which are new, kind of newish, long-acting lipoglycopeptides. These antibiotics work for 2 weeks. You get one injection and they treat for 2 weeks. So if you need antibiotics for 2 weeks, all you need is one injection. They're initially FDA approved for skin and soft tissue infections, so not for pneumonia or lung exacerbations. We use them off-label in osteomyelitis, bone infection, and infective endocarditis, heart valve infections. And in terms of lung penetration, it's unknown, but there are several case reports talked about successful treatment of MRSA pneumonia or VRSA pneumonia. So they might work. Telavancin is another one in the same family, but it's approved for pneumonia, especially hospital-acquired pneumonia. And ciftereline has in vitro activity, works in the lab, but we don't know if it works in real life. And there's the combination therapy, mostly linezolid and daptomycin, ciftereline, telavancin, and that's the last resort. So we're done with Staph aureus. We have another case, a 32-year-old male with cystic fibrosis presented with increasing cough and sputum production over the 7 days with fevers. shortness and breath, and fatigue. That patient had multiple pulmonary exacerbations in the past with frequent antibiotic courses, current medication Trikafta, inhaled tobramycin, and azithromycin. The chest X-ray showed new infiltrates in the right lower lobe with underlying bronchiectasis, and sputum culture shows Pseudomonas aeruginosa. As you can see here in the susceptibility testing, we have all R's and I's. So cefepime doesn't work, ciprofloxacin or levofloxacin don't work, meropenem does not work, and piperacillin tazobactam or Zosyn does not work, and even tobramycin is intermediate. So we asked for that case for additional susceptibilities. I asked for 3 more antibiotics, and luckily one of them worked, called ceftalozane tazobactam, or the brand name Zerbaxa. The patient was treated with Zerbaxa and did well. So that brings me to talk about Pseudomonas aeruginosa with difficult to treat resistance. Pseudomonas is a key gram-negative bacteria. This organism is important in cystic fibrosis because, as we said earlier, it often leads to chronic infection and can be resistant to several antibiotics. MDR, or multi-drug resistant Pseudomonas, is defined as Pseudomonas not susceptible to at least one antibiotic in at least 3 antibiotic classes. So that includes penicillins, cephalosporins, fluoroquinolones, aminoglycosides, and carbapenem, as we saw earlier in the case. In 2018, the concept of DTR, or difficult to treat resistance, was proposed. And that's defined as Pseudomonas exhibiting non-susceptibility to all the following antibiotics: piperacillin tazobactam, ceftazidime, cefepime, aztreonam, meropenem, imipenem, ciprofloxacin, and levofloxacin. These antibiotics that we usually use to treat Pseudomonas. So with these antibiotics gone, we're very limited. And if you look at the prevalence of multi-drug resistant Pseudomonas, it goes up and down, especially with age, but Pseudomonas in general has been increasing as we get older. This table shows the regular antibiotic that we use for typical Pseudomonas, but once it's resistant, we cannot use any of those. So that brings me to the new beta-lactam agents. And these are ceftalozane tazobactam, Zerbaxa, the one that we used in the case. And it is active with 90% against all the isolates of Pseudomonas. Second option, or second line, is ceftazidime avibactam, or avicas, with 85% chance of working. And then less likely, and one of the carbapenems is imipenem brelibactam, or Ricarbrio, which works in 86% of cases. What if you ask me, what if all these and new beta-lactams agents do not work? What if we have a really nasty Pseudomonas that is resistant to even these 3? We have one last option, which is cefidricol, or Fitrusia. This is our last resort in terms of antibiotics. It's kind of works in a really weird way. It's Sidra4 antibiotic. Sidra4 comes from the Greek word iron carrier, which in this case are small compounds that are produced by the bacteria to help transport iron across cell membranes. Cifidrocol acts in a really cool way. It acts as a Trojan horse. It pretends to be an iron to sneak through bacterial wall, then kills the bacteria once inside. So now cifidrocol is the last antibiotic option. Once we run out of cifidrocol, we're talking about things like phage therapy or a combination of multiple antibiotics with intermediate susceptibility. Case 3, we have a 25-year-old female with cystic fibrosis, 10-day history of worsening cough and increased sputum, and low-grade fevers. Chest X-ray again shows patchy opacities in the bilateral lower lobes, and the culture grew Stenotrophomonas maltophilia. This bacteria is intrinsically resistant to a lot of antibiotics. So we have few options to begin with. The first line, we use trimethoprim sulfa, but there are a lot of people who have sulfa drug allergies. And if we're lucky, just like this case, can be susceptible to levofloxacin and minocycline. Stenotrophomonas is another gram-negative bacteria that's mostly found in water. It produces biofilm and virulence factors that enable colonization or infection in those with underlying lung disease, especially cystic fibrosis patients. It has a lot of enzymes, and these enzymes act on certain antibiotics to make them useless, like penicillins, cephalosporins, carbapenem, or even aztreonam. It also has intrinsic resistance to aminoglycoside, like tobramycin, amikacin, etc. Also can accumulate drug pumps that also reduce the activity of Bactrim, tetracyclines, and fluoroquinolones by pushing the antibiotics outside the cell. In terms of treatment approach to this bacteria, we usually recommend 2 antibiotics to start with uh, until we get the susceptibility back and know for sure which antibiotic works. And that could be any of the following: cifidrocol, minocycline, Bactrim, or levofloxacin. And in highly resistant cases, we use a combination of aztreonam, ceftazidime, avibactam, but there's limited clinical data to support it, mostly case reports. There are no research or clinical trials to see the results. In terms of monotherapy versus combination, the clinical outcome data comparing those two are conflicting and limited to observational studies. In practice, we usually do monotherapy if the infection is mild, but if we're talking about moderate to severe infection, we prefer combination therapy, especially in immunocompromised patients. There was a multi-center observational study that looked at 307 patients with Stenotrophomonas pneumonia, and they compared combination therapy to monotherapy. They found that there is no difference in overall 30-day mortality in combination therapy compared to monotherapy, but was associated with reduced mortality in immunocompromised patients and in severely ill patients with a PACHI score of 15 and greater. A PACHI score is a score that we use to assess the severity of the condition or the severity of infection. So that tells us in summary that we should try to do combination therapy for Pseudomonas to start with in severe infection, severe pneumonia, or an immunocompromised patient. but monotherapy might work in mild infections or mild to moderate. Case 4, we have a 25-year-old female with cystic fibrosis who had a liver transplant 2 years prior to her presentation because of MASH cirrhosis. She presented with cough for a week, new fever, and then her cough was getting worse and worse, and her phlegm was getting worse. Her CT scan showed signs of necrotizing pneumonia. She was admitted to the ICU and subsequently intubated. They did another repeat X-ray, showed patchy opacities in the bilateral lower lobes with no changes in her necrotizing pneumonia. And the cultures came back with Burkholderia cepacia complex. Luckily, it was susceptible to meropenem and Bactrim. However, that patient was allergic to Bactrim, but the type of allergy was not real and was documented as nausea and vomiting. So when we dig through the chart and we ask her family, apparently she had some nausea. We tried combination therapy of meropenem and Bactrim, and the patient improved significantly. But in this case, she had cepacia syndrome, which I'm going to talk about in the next slides, which require further treatment of antibiotic for a longer duration. Burkholderia cepacia complex. The genus Burkholderia was discovered in 1949 by Walter Burkholder while analyzing the skin of rotten onion fragments. The name cepacia comes from the Latin word cipa, which means onion, and that makes sense given that he discovered it while examining the skin of onion. In CF patient, it's associated with accelerated lung function decline, increased inflammation, and higher mortality compared to Pseudomonas and Staph aureus. Persistent infection can lead to cepacia syndrome. And in terms of classification of Burkholderia cepacia complex, it's kind of complex classification. We use something we call it Genomovar, and there are 10 of them. The first 5 are basically associated, or 6 are associated with cystic fibrosis. Cenocepacia is the worst one because a lot of centers in the United States consider that a contraindication for lung transplant, but not the other ones. And Delosa caused an outbreak from 1998 to 2005 in Boston Children's Hospital in cystic fibrosis patient. Cepacia syndrome. What is cepacia syndrome? It's a syndrome that consists of mainly necrotizing pneumonia, respiratory failure, high fever, plus minus bacteremia. It's rare and not that common. There were 18 cases of cystic fibrosis documented in literature. The median age was 22 years old, and the median time from the first infection with that bacteria to the development of cepacia syndrome in that cohort was 5 years. And the bacteremia or bloodstream infection with that bacteria was identified in 11 cases out of 18. These are the 18 cases reported in the literature with their age, the antibiotic used for the treatment, and other adjuvant therapies, and the outcome for these patients. Only 9 out of 18 survived, so it has really high mortality, 50%. Bactrim or trimethoprim sulfa was the most frequently administered antibiotic for these patients. They found out that inhaled and nebulized antibiotics were prescribed in about 5 patients, all of whom survived. An immunosuppressant agents were administered in 7 out of 18. And the idea of using immunosuppression was thought because of that severe pneumonia causes the immune system to fight the bacteria aggressively, and that inflammation that the immune system causes further damage to the lungs. So using immune suppressant medication to suppress the immune system a little bit to decrease the inflammation while using antibiotics to kill the bacteria will help reduce the damage to the lungs while the lungs recovers from the infection. So what antibiotics can we use for Burkholderia? As we mentioned earlier, we can use meropenem, levofloxacin, and Bactrim if susceptible. But if we're facing resistance or issues with antibiotic intolerances or allergies, we can use certain alternative agents like minocycline, ceftazidime avibactam, imipenem, cefidricol. Timoxeline is not available in the United States, but can be used in United Kingdom. So that's what we use in Burkholderia species complex. And there are certain case reports where they use also adjuvant therapy with immune suppressant in addition to antibiotics. That brings me to case 5. A 37-year-old man on modulator therapy and has type 1 diabetes presented to the hospital for evaluation of shortness of breath and worsening cough. He's unable to produce sputum, and the CT chest showed right lower lobe pneumonia. So he underwent a bronchoscopy with bronchoalveolar lavage, and they sent cultures. The cultures came back with a Chromobacter. And if you look at the susceptibility, it's all R's. So this was a really highly resistant infection. So we requested additional susceptibilities to be done for this bacteria. And we requested antibiotics like the one that we mentioned, cefidricol, that works like a Trojan horse, imipenem, and eravacycline. And luckily it was susceptible cefidricol, but none of the other antibiotics. So cefidricol was his only option. So we used cefidricol to treat this infection. So a Chromobacter is basically a gram-negative bacilli found in soil and water, and it has intrinsic antibacterial resistance mechanisms. It has multiple enzymes that break down antibiotics. That's why it's highly resistant. And also has multi-drug efflux pump to push the antibiotics out of the cell and can develop further resistance by using that first mechanism. It's also predictably resistant to all of these antibiotics. So like the penicillins, the second generation cephalosporin, ceftriaxone, aztreonam, etc. So what do we use? There is no standard treatment protocol for cystic fibrosis pulmonary Chromobacter infections. And the treatment usually consists of systemic and or inhaled antibiotics, and we use likely a combination therapy until we wait for the susceptibility. These are the antibiotics that we can use, usually ceftazidime, but in our case was resistant, imipenem, celastin, or meropenem, or inhaled antibiotics with ceftazidime, colistin, or tobramycin. Salvage therapy, cefidricol, the one that we use for our case, and he did well. Case 6, this is a 35-year-old male with cystic fibrosis, had like 2 months history of progressively worsening cough, low-grade fevers, fatigue, and unintentional weight loss. The CT chest showed bilateral bronchiectasis with multifocal nodular infiltrate and something that we call tree in bud opacities, which is very particular to mycobacterial infection. So she underwent a bronchoscopy with cultures, and the bronchoscopy showed Mycobacterium abscesses. The susceptibility is here, as you can see. Cefoxietine is an intermediate. Imipenem is susceptible, but that's an IV option. And then tobramycin is another IV to inhaled option, but we cannot use inhaled initially, at least for this case. And linezolid. Linezolid is an antibiotic, as we mentioned earlier, that we can use to treat a lot of infections, especially Staph aureus. But once we hit that 2-week mark on the antibiotic, we'll start to notice anemia and low platelet counts, which limits its use for a long duration or long infections or severe infections like mycobacteria. So non-tuberculous mycobacteria, or NTM, these are aerobic bacteria that love air, non-motile, do not move, and gram-positive, with thick layers, with thick membranes. The main risk factors for developing the infection, as you can see here in the image, I'll highlight a few things like cystic fibrosis, chronic aspiration, which results from reflux disease, because all of that acid comes back to the lungs and causes chronic lung damage. Aging, just getting older puts you at risk of these infections because of that recurrent damage to the lungs. And recurrent respiratory infections, which happen in cystic fibrosis. The most common ones are MAC, or Mycobacterium avium complex, followed by M. abscessus and Chelone. And I could talk about NTM for a whole week because it's like very complex topic and very complex infection that requires at least a year of therapy, of antimicrobial therapy. We have certain diagnostic criteria, and we have to be very careful when we diagnose this disease. We have, first of all, the clinical criteria, which are non-specific. Pulmonary symptoms and systemic symptoms like loss of weight, fevers, cough, phlegm production. Radiological findings that, like the one that we mentioned earlier, underlying bronchiectasis and tree and bud nodularities. And both clinical and radiological features are required to diagnose the disease. We also have to rule out other diagnoses or other causes. And finally, we have the microbiologic criteria. So for the microbiologic criteria, one sputum culture is not enough to diagnose the disease. We need at least 2. Or one culture that comes from bronchoalveolar lavage, from a bronchoscopy sample. So 1 bronchoscopy or 2 sputa. Then the third other criteria is 1 sputum sample plus a lung biopsy with evidence of mycobacterial growth. And if you look at the percentage of individual with positive microbacterial culture, we can see that the median was 76 in those who do not use chronic macrolide therapy and was 80 in those who use chronic macrolide therapy. What I mean by chronic macrolide therapy is azithromycin, chronic azithromycin in CF patients. That's why CF patients should be screened before and 6 months after beginning chronic azithromycin therapy and annually after that. Because azithromycin is one of the cornerstone antibiotic to treat mycobacterial infection. So I'll talk about treatment. It's busy, complicated, In this slide, we're talking about the treatment of avium complex MAC, Kansai, and Xenobi. Kansai and Xenobi are really rare, not that common as MAC, but MAC is common. The treatment can be quite complicated. So for MAC, our approach really depends on the imaging findings and the severity of the infection. And these factors will guide our decision on whether to use 3-drug regimen, 4-drug regimen, or sometimes even more intensive therapy. Um, and that depends on the susceptibility of that specific bacteria. But in most cases, we're lucky enough to start 3 oral antibiotics. In some cases, we'll have to do some IV for a while before we transition. For abscesses, it's even more complicated because it's far more resistant to antibiotics, as you saw in the case earlier, and that leaves us with very limited therapeutic options. It depends largely on azithromycin or macrolide inducible susceptibility. So what do I mean by macrolide inducible susceptibility? Some bacteria, like M. abscessus, can have like a switch on resistant to macrolide antibiotics. So like azithromycin. So they initially test susceptible, but when exposed to that specific antibiotic, they switch immediately to resistant. And so to overcome that, we do susceptibility or inducible susceptibility. So the report comes back with susceptibility testing to different antibiotics, but then we'll have to wait for another 2 weeks to make sure that this antibiotic, especially azithromycin, is still susceptible. So based on that result, we'll have to come up with an initial phase of treatment and a continuation phase. And that takes a year from culture clearance. Finally, I'll talk about few things here. I'll rush given the time. Optimal duration of antibiotic depends mainly on a trial that we did called the Stop at 2 trial. And in that trial, they enrolled 982 participants. All of them received 7 to 10 days of initial treatment, and they were randomized either to early responders or slow responders. Early responders, they found that 10-day course was non-inferior to 14, but in slow responders, they found out that 21 days was not superior to 14. That's why we usually treat for 14 days for usual infections, sometimes extend to 21 in highly resistant infections. In Cepacia complex or Cepacia syndrome, sometimes we extend to 6 weeks. And Mycobacteria is a completely different world because we treat for a period of a year from culture clearance. And this is the median duration of antibiotics that cystic fibrosis got in 2023. And to quickly talk about new and future antimicrobials, I'll quickly talk about what we use right now in amikacin inhalation, azithromycin, and histrionam. But then obliconazole is something that we use for aspergillus and still under development. Intravenous gallium works in a similar fashion to cefidricol as a Trojan horse. BX04 is a type of phage therapy for Pseudomonas, and you had a talk about phage therapy, so I'm not going to expand on this. And CMTX is also an anti-infective therapy that disrupts the biofilms. Amikacin is something really that exciting because it works for Pseudomonas based on the TransSafe trial and also works for NTMs, and it's a great option for NTMs and uses the nebulizer machine system to help clear NTM. Chronic azithromycin, we use it for Pseudomonas, but mainly for the anti-inflammatory effect, not for the antibacterial effect. And as we said, we need to do that screening test for NTM before we start and periodically after. Aztreonam is another option for Pseudomonas. It's an inhaled option, and it has really great results based on the trials. Um, my final message here is fighting antimicrobial resistance takes all of us. Every nurse, doctor, researcher, patient, and community member has a role to play. So together we can make a difference.